Hey everyone, it's Nurse Sarah, and in this video, I'm going to be going over meningitis. And as always, don't forget to access the free quiz that will test you on this material. So let's get started. What is meningitis? Well, let's take this word apart. We have the prefix meninge, which means meninges, and then we have the suffix itis, which refers to inflammation. And when we put all that together, we get inflammation of the meninges. But what in the world are the meninges? Well, they are a three protective layer that surrounds the brain and the spinal cord. And what they do is they work to cushion, hence pad, and protect our central nervous system. Now, unfortunately, these layers can become inflamed. And whenever they do, they can lead to serious complications that you're going to see in a patient who has meningitis. So to help us really understand meningitis, we've got to take a deeper look at each of these layers. And to help you remember those layers, remember a mnemonic I created called PAD. And how this mnemonic will work is that P is going to start with that inner layer, and then once we get to D, we're talking about the outer layer. First up is the pia mater. This is the innermost layer, and pia actually comes from Latin and means tender, delicate. So this layer is very tender and delicate, and what it does is it sticks directly to our brain and spinal cord. And it's highly vascular, so it helps deliver nutrients and oxygen to our CNS. Next is the arachnoid mater. This is our middle layer, and the word arachnoid comes from Greek and is associated with spider-like. So what's one thing that we all associate spiders with? Creating web-like structures, and that really helps describe this layer. So this layer is a thin web-like layer that has these web-like fibers called trabeculae that extend down into that innermost layer, the pia mater, and it's going to help form a very important space I want you to remember called the subarachnoid space. And this space is going to contain our cerebrospinal fluid, our CSF. And you really want to remember about CSF because that is one of the things that we take to help diagnose a patient with meningitis. And then lastly, we have the dura mater. This is the outermost layer. Now, to help you remember this layer, think of the English word durable. That means strong and tough. That really describes this layer. It's a layer that's extremely strong and tough, and you're going to find it just below the skull bone. Now, above this layer is a special space called the epidural space, and then below this layer is the subdural space. And you may hear epidural and subdural related to hematoma, and that is what is talking about whenever we're talking about the hematoma, because a hematoma is like a collection of blood outside of those blood vessels, so a pocket of blood. And here you can see an example of those. Epidural hematoma, we have that pocket of blood that's hanging out just above that mater, and then the subdural hematoma is hanging out below that mater in that space. So now that we went through all of those layers, you may be wondering which layers are most affected in cases of meningitis. Well, in most cases of meningitis, it tends to affect the pia mater and the arachnoid mater. And you may hear these maters sometimes referred to as the leptomeninges. Now, why doesn't it tend to affect the dura mater, which is sometimes referred to as the pachymeninges? Well, think about the location of your dura mater. It is the outermost layer, so it's further away from that cerebrospinal fluid, which is where our pathogen gets in, sets off that immune response, and then we get the inflammation, which is going to carry over into the pia mater and the arachnoid mater because it's so close to the CSF. Plus, that dura mater is very durable, it's strong, it's not very vascular, so it's not going to have a lot of immune activity. Now let's talk about what can inflame those meninges, hence those layers that we just went over. Well, this is where we start getting into the different types of meningitis, where we have infectious versus non-infectious causes. So with infectious, it can be caused by bacteria, viruses, fungi, or parasites. And bacteria is going to be the most serious and deadly type of meningitis. And it's most commonly caused by Neisseria meningitidis, Streptococcus pneumoniae, and Haemophilus influenzae. And notice I have these little asterisks behind these names. That's just letting you know that there are preventative vaccines available for these types of bacterial meningitis. And we're going to go over that in depth whenever we go over the nursing considerations. Then we have viruses, and this is the most common cause of meningitis, known as viral meningitis. And it typically is caused by the enteroviruses and herpes simplex viruses. Then we have fungi, which can be caused by Cryptococcus, histoplasma, and then parasitic, which can be caused by Naegleria fowleri, which is most commonly known as the brain-eating amoeba. Then our next type is the non-infectious types of meningitis, which can be caused by autoimmune conditions such as lupus, multiple sclerosis, medications like NSAIDs, antibiotics, or some type of trauma where the patient's had brain surgery or some type of head injury. So now that we've talked about the different layers of the meninges and how those layers can become inflamed, now let's talk about the pathophysiology, because if you can understand the pathophysiology, it's going to make so much more sense when you're trying to recall these signs and symptoms, think about your nursing considerations and the treatments for the patients that you need to know for exams. So what I'm going to do is I'm going to concentrate on the patho of the infectious types of meningitis, so those types where pathogens get in the body and inflame those layers like the bacteria and viruses. Okay, very first step is that pathogen needs entrance into the body, and it can do this various ways. It can get in directly to your bloodstream or direct extension through your ears, your sinuses, or even a procedure trauma. Whatever, a doorway has opened and it has got in. Once it gets in, it invades wherever it got in. So let's say, here's our little germ guy, he has got in to our bloodstream. Once he gets into our bloodstream, he's just going to float through circulation. One of those areas of circulation he has to go through is the central nervous system, our brain. But luckily, under normal, healthy circumstances, that brain, central nervous system, has what's called the blood-brain barrier in place. And it prevents, just as its name says, things that are bad in your blood from being able to cross over into your brain. Hence, it makes a barrier. And how this barrier is set up in very simple terms is that there's these specialized blood vessels in your central nervous system, your brain, that have tightly packed endothelial cells. Also, it has a basement membrane that prevents toxins, pathogens, and certain medications from crossing over. And surrounding it are these special cells like pericytes and astrocytes. So they're going to be extremely on guard of what's crossing over from that blood into the brain. But unfortunately, pathogens have got really smart. And some of them, I have learned, can actually sneak across from your blood onto a white blood cell and cross over from the blood from the vessel into the brain. So they like sneak a little ride on the white blood cell who doesn't know it. So once it does that, that's what our little guy has done here. He's crossed over. He is going to enter into the subarachnoid space. And the subarachnoid space contains our cerebrospinal fluid, which is normally sterile. So once he's in there, the immune system is going to detect this. It's going to respond. Now, luckily it does this, but once it does this, it sets off like a chain of events that's going to cause some pronounced signs and symptoms in your patient. So how the immune system is going to respond is it's going to cause a bunch of white blood cells to rush to the cerebrospinal fluid in hopes of eradicating that pathogen that just entered that subarachnoid space. Now, there's two things I want you to remember for exams. If this is bacterial meningitis, you're going to have a high number of neutrophils in that cerebrospinal fluid. Where on the flip side, if it's viral meningitis, you're going to have a high amount of lymphocytes in that CSF. Now also, cytokines are going to be released, and these things are really handy. They're chemical messengers that are actually going to recruit more immune system cells to come and help fight the fight of what's causing the inflammation in those meninges. But because they do that, they cause inflammation and they're going to increase vascular permeability, which is actually beneficial for immune system, but doesn't feel too good to your patient, leading to our signs and symptoms that you want to remember. These signs and symptoms include fever. So with bacterial meningitis, that fever is going to come on suddenly and it's going to be 102 or greater. Whereas with viral, it's going to come on more gradually and be about 100 to 101. In addition, because we have swelling, increased vascular permeability, plus these structures in here, such as the arachnoid villi, these are the little villi that hang out in the subarachnoid space that help reabsorb cerebrospinal fluid, they're not going to be working like they should. So you're going to have impaired outflow of cerebrospinal fluid. And all this is going to set up a storm for increasing the patient's intracranial pressure. And this can present with neuro changes. It could even go to a seizure if it got really high, nausea, vomiting, and just a severe headache for your patient. Plus, because our motors are inflamed, it's going to affect the way the person can move their neck. So whenever they try to bend their chin to their chest, so bend that neck forward, it's going to be extremely painful, or they may not even be able to do it at all. The proper term is nuchal rigidity. Because our motors are inflamed, that irritation can extend to the nerves and it can cause photophobia, where bright lights will hurt the patient's eyes and they'll have vision changes like blurred vision. And then lastly, there are 2 signs that I want you to remember for exams, because a lot of times they like to ask you the differences between these 2 signs. They are the Koenig sign and Brzezinski sign. To check for Koenig sign, you want the patient to be in the supine position. Then you want to flex the hip and knee at 90 degrees and then extend the knee while keeping the hip flex. And note if the patient has any pain or resistance to this extension. If they do, it is a positive Koenig sign. To check for Brzezinski sign, you want the patient to be supine and you want to flex the neck to the chest. If it's positive, the patient's going to experience pain, but there's also going to be flexing of the hip and knees. Now, it's really easy to get those 2 signs confused, and how I remember them is that I look at the letters of the name. So with Koenig's, you have a K and an E. So remember that there is pain when you have knee extension. And then with Brzezinski, I remember with the B, you're bending. That's the big thing. You're bending the neck. And they're going to get in like a skiing position where they're going to flex their hips and their knees. So maybe that'll help you. Now, it's important to know that these signs and symptoms I just went over, they are going to be in your adult patient. In the pediatric patient, especially if they're less than 2 years of age, they're not going to have these traditional signs and symptoms. They're more going to have non-specific ones where they're going to be refusing to eat. They could have bulging fontanelles if those fontanelles are still open. They can be crying a lot. They can't be consoled. They can be lethargic or even seizures. So with adult, remember the big ones that you're mainly going to see. So if you have a patient come in, they're going to have that nuchal rigidity where they're going to have neck issues. They're going to have severe headache and fever. That's like a big 3 of your meningitis signs and symptoms. Therefore, whenever the patient does have those signs and symptoms that we just went over, it's really important that they get a diagnostic workup to see if this is indeed meningitis. And if so, what type of meningitis is it? Is it bacterial, viral, or is this even non-infectious? Because that is going to help streamline the treatment that the patient is going to receive. So, workup's going to include laboratory work like blood cultures, nasal and sputum swabs, imaging like CT scans, MRI of the brain, also a lumbar puncture. This is one of the huge things that a patient's going to need if they do suspect meningitis, because this is going to help confirm the diagnosis and identify the cause. Now, I have a whole lecture on lumbar puncture that you definitely want to check out to help you prep for your exams, but I'm going to pull 4 important things that you want to know about LPs. One thing is that before the patient has the procedure, it's really important that we check if they are on any anticoagulants, because they don't need to be on this because it can increase the risk of a hematoma. Plus, we want to check their INR levels and their platelet levels. In addition, some protocols, depending on the facility you're working at, so always look at protocols, may require that your patient be nothing by mouth before the procedure. This is especially true if the patient is young and they can't cooperate because you have to lie really still for this, or if the patient is confused. They may need general anesthesia. Positioning, you want to inform your patient about the positioning and that your patient can get in this position. For instance, depends on the provider how they want them positioned, but it could be sideline where the knees are flexed, like the fetal position, or prone with the hips slightly in the oblique position, or they're setting and leaning forward. And then lastly, that post-procedure. So a lot of times your patients will be coming back to you. Let's say they go to interventional holding, then they come back to the room. You want to be familiar with what you have to look for. So you want to make sure that your patient lays flat for at least 1 to 2 hours after they have this, where their head isn't getting any higher than their bottom, because they just penetrated that sac in there. And what can happen is they can have a cerebrospinal fluid leak, and this can lead to an intense headache. So make sure that they lay flat for that amount of time. In addition, if they do develop a headache, you want to make sure that they aren't in this upright position or walking around, because that can make the pain worse instead of lying flat. Makes it better, and that they are consuming fluids to help replace that cerebrospinal fluid that was removed. And some studies have said that drinking caffeine can help because it can help vasoconstrict and decrease the headache. Now what I want to go over are those cerebrospinal fluid findings you're going to see after the lumbar puncture. And you want to commit this information to your memory because a lot of exam questions like to ask about the findings in the CSF versus bacterial and viral. So first up, whenever they do a lumbar puncture, one of the first things they're going to be able to assess is that opening pressure. Anywhere normal is about 5 to 15. In bacterial meningitis, it's going to be really high, whereas in viral, it's typically normal. With the appearance of this CSF in bacterial meningitis, it's going to be cloudy. The reason for this is because there's mainly neutrophils in that CSF with bacterial meningitis, and they are granular. Plus, there's going to be high amounts of protein and bacterial debris, so you get this cloudiness to it. With viral, it tends to be clear. The glucose in the CSF in bacterial meningitis is going to be low because the bacteria are eating them. So it's going to be less than 40. In viral, the glucose will be normal. White blood cell count is going to be high in both, so bacterial, it's going to be very high, and it's mainly going to be neutrophils in there. With viral, it will be high, mainly lymphocytes. With protein, with bacterial meningitis, the protein will be high. And the reason for this is because whenever neutrophils come, there's a lot of them that come to our CSF, but because they come, we're going to have a lot of inflammation going on, and whenever we have inflammation, it actually increases vascular permeability and we get the leaking of protein. With viral, there's going to be slightly high protein. And then with cultures, with bacterial, when they culture it, of course it's going to grow cultures, and that will help us identify it. With viral, our cultures will be negative. Now let's go over the treatments and the nursing considerations for meningitis. So the treatments are going to vary depending on the cause of the meningitis, and that's why that lumbar puncture is so important. So what I'm going to do is I'm going to take this by each type of meningitis. So first we're going to start with bacterial. Again, this is the most deadly out of all the types, and it needs proper treatment immediately to prevent death. So treatment's going to include IV antibiotics, and they're going to be started on antibiotics before we even know the cause. So they're going to start them on empiric antibiotics like ceftriaxone plus vancomycin, just to give you an example. And this is to help just get the patient on something while we're waiting for those results to come back. As a nurse, your role will be administering those antibiotics, so you want to administer them on time, you want to watch for side effects, make sure the patient's not becoming toxic, look at the renal and liver function through the tests like BUN and creatinine, their ALT, ALP, AST, and collecting any peaks and troughs that may need to be drawn. Now, once their test results start rolling in, like their blood cultures, their CSF, those antibiotics may be switched to something else more tailored to target that bacteria that's causing the infection. But when you have bacterial meningitis, time isn't on your side, so you got to get something in this patient. Also, sometimes corticosteroids are used like dexamethasone, and this will help decrease inflammation and could prevent hearing loss. One thing you want to remember this is that this should be given before or with the first antibiotic dose to be most effective. Isolation precautions need to be initiated, such as droplet, especially if the patient has Neisseria meningitidis or Hib, and this is until 24 hours after antibiotics have been started or whatever your hospital protocol dictates. And airborne precautions if the patient has TB meningitis, and this is until they're non-infectious. Now, there are preventative vaccines that are available for some types of bacteria that can cause meningitis, such as Hib, the Haemophilus influenzae. This is given in 4 doses during the childhood vaccine schedule at 2, 4, 6, and 12 to 15 months. The pneumococcal vaccine, which helps prevent Streptococcus pneumoniae, it is also given during infancy. The childhood vaccine schedule in 4 doses is the same as the Hib, and 1 dose can be given to older adults 65 or older. There's also meningococcal, which is for Neisseria meningitidis, and this is given in 2 doses during the childhood vaccine, which is started at anywhere between 11 to 12 years old, plus a booster at 16. Next is viral, and this is serious but less life-threatening than bacteria. So antivirals can be given for this, especially for the herpes simplex virus meningitis. With this, it's mainly supportive care, treating the pain, fever, making sure they're hydrated. And for fever, you want to give acetaminophen. However, you want to completely avoid opioids or sedatives because it can mask the neuro changes that we see whenever the patient has increased intracranial pressure. With precautions, patients are going to be in standard precautions for most of the viruses. However, again, check your protocols. And if the patient has herpes simplex virus lesions or the enterovirus in incontinent children, they'll need to be in contact precautions. For fungal and parasitic, these are rarer than the previous types we just went over. So for fungal, IV antifungals will need to be given for several months, and you'll need to tell the patient that this is going to take long-term commitment and to emphasize that they need to adhere to treatment so it actually will clear the fungal infection. For parasitic, it's supportive care and antiparasitics can be given if indicated, and precautions would be standard for both. And then lastly, for non-infectious meningitis, the key is identifying what is causing the meningitis. Is it medications? Well, stop them. If it's autoimmune, figure out what specific autoimmune it is and then treat it if it can be treated, and teach the patient on how to avoid triggers. And it's going to include supportive care with pain and fevers. Now, some other nursing considerations you want to keep in mind is that you want to monitor their temperature very closely, because remember, high fevers can increase intracranial pressure and we don't want to do that. So the best and most reliable way to check their temperature is through oral temperatures, and you want to treat those temperatures per protocol. Also, you want to be doing neuro checks regularly to make sure that intracranial pressure is not increasing. Early signs that it's increasing is that you're starting to see neuro changes where they're becoming restless, confused, they're starting to have an increased headache, or they're having changes to their vision or vomiting. Late sign would be that they're having seizures, or you're seeing that Cushing's triad where you have the bradycardia, widening pulse pressure, and irregular breathing. Now, the environment is really important as well, because we don't want to agitate their neuro system, which is going to increase intracranial pressure. So we want to make sure we keep low stimulation, the room is dark and quiet. We keep those invasive procedures at minimum, especially if they need suctioning. Too much suctioning will increase intracranial pressure. You want to keep the environment cool. You don't want it too hot. That increases intracranial pressure, but you don't want them to be so cold that they're shivering, which increases intracranial pressure. Medications you want to avoid, as I pointed out earlier, is opioids and sedatives, and you want to make sure you position them properly. So you want the head of the bed about 30 to 45 degrees, because this is going to help promote blood return to the heart. You also don't want to flex the neck, because that will impede blood flow. And keep that head midline, and watch the hip flexion, because this can increase intra-abdominal pressure, which in turn can increase intracranial pressure. Okay, so that wraps up this review over meningitis. And if you'd like to watch more videos in this series, you can access the link in the description below.